Hello, I'm Nick Majerison. This is Top Med Talk. EBPOM USA, Chicago 2018. The Opioid Crisis. Can we kick the habit? Recorded at the recent Evidence Based Perioperative Medicine, that's EBPOM for short, USA conference, this piece, in less than 10 minutes, lays out the case for kicking the opioid habit. Specifically in America, but of course, anywhere you practice, you have to be aware of the dangers of opioids. Use this piece to help build the case for reducing your use of opioids at your institution. Presented by Matthew McEvoy, Vice Chair for Educational Affairs and Professor of Anesthesiology at Vanderbilt University Medical Center. Have a listen.
Top Med Talk.
To wrap up the evening, we are going to be talking with Matt McEvoy, and he's going to be talking to us about the opioid crisis here in the U.S. Dr. Matt McEvoy is Professor of Anesthesiology at Vanderbilt, and he is the Vice Chair of Educational Affairs there. So the opioid crisis, can we kick the habit? Matt, can we?
Well, we'll see.
Let's hear it.
So, crisis, any event that is ongoing or is expected to lead to an unstable and dangerous situation affecting an individual, group, community, or whole society. In 2016, 116 people died every day from opioid-related overdoses in the United States. 11.5 million people admitted to misusing prescription opioids. And there's a few more numbers there as far as in that year alone, over 2 million misused a prescription for the first time. Over 17,000 deaths were attributed to overdosing on commonly prescribed opioids, the codones being the most common. 19,000 additional deaths with synthetic opioids other than methadone, and another 15,000 related to heroin. If you look at this, I want you to pay attention here. See this square up here that says decrease, okay? Notice how many orange states you're going to see. This is all drug overdoses. This is data from the CDC. Okay? Opioid-related overdoses, you're noting that there was no significant increase, but there are still no orange states. And you see some that are increasing. Heroin overdoses, Vanderbilt, of course, is right here, and you notice that we've been in the wrong color the entire time. New Hampshire is the only one in all three of those categories that you're actually seeing a decrease. So, Houston, we have a problem. I think we have a crisis. But the question is, can we kick the habit? And I want to break this apart. So, the habit, what is it? And I'm going to insert there that it's actually the U.S. habit. Opioid consumption. How many of you watched Sesame Street as kids? Yeah? Okay. Do you remember the game, which one of these kids is not like the other? So, if you're not good at reading bar graphs, it's this one. Okay? So if you look at it by all sorts of opioid classes, we are consuming in America somewhere between 80 and 90% of all opioids used in the entire world. Now, we have colleagues from the UK who are here. Do you do colectomies in the UK? Joint replacement, back surgery. Okay, so you actually do major... Okay, so they actually do the same surgeries and use less opioids, okay? Now, this has occurred in three waves. If you notice these three waves, the first one was in the late 90s with pharma pushing a lot of the opioids and pain becoming the fifth vital sign and all of these things. There was the initial wave, the top one here, this purple line, of a rise in prescription opioid-related overdose deaths, okay? The second wave, the gold bar there, in about 2010, we started to see a sharp uptick in the rise of heroin-related deaths. And then the third wave is what we're seeing now, which is the rise in synthetic opioid-related deaths. Okay, so we have three tidal waves that are hitting us and have been hitting us for some time. Who's the we? How many of you are Lord of the Ring fans? Right? My precious. If you don't know that, look at someone who raised their hand. Okay? This little creature here just could not live life without this ring. To the point that actually at the end of this movie falls into the fire and dies himself, having to clutch on to his precious. Now, we often tend to think society is this golem creature. In fact, it's us. And we think, how do we possibly provide perioperative care without opioids? Now, this slide actually comes from people in the Michigan Open. I saw it at a meeting last week, and they provided their slides to the group, and so I want to give them credit for it. But what happens is we have an opioid-naive patient who comes in. They have surgery, and then often we can have some percentage that go into chronic opioid use by our prescribing practices. Other patients who go home with more than they need, and we have opioid diversion into the community, and that leads to this opioid epidemic. And there are a tremendous amount of papers, I've cited just 4 or 5 of them there, that actually show this phenomenon going on. Now, there's good news, bad news. From 2016 to 2017, good news, 12% decrease nationally in opioid prescriptions. Bad news, opioid-related deaths are still on the rise. So you saw the semi-synthetics and the heroin is really driving that. Now, our current starting point, we hear opioid prescriptions are going down, right? Which size of fries do our opioid prescriptions correspond to right now? Okay? There's a little, spoiler warning there if you want it, right? We're doing a little bit better. The problem is we're already starting at like the super size when we think about our starting points. We have a long way to go. Depending on who you read, there's 50 million patients who undergo surgery per year in the United States. At least 10% of those will be new chronic users after surgery. That's cited anywhere from 3% to 26%. The study that showed this with 10%, particularly related to colorectal surgery, did not include thoracic, did not include breast, did not include a lot of the major surgeries where we get concerned. It also did not include wisdom tooth extractions, which is 2.5 million patients per year have that in the United States. 70% overprescription at discharge. There's evidence showing it was 72% is what's actually cited in the paper, that when you begin to do audits on patients, they tend to have many more pills than they actually ever use, but they're sitting out there in the community for someone else to use. You go, big deal, if they're not getting hooked. 80% of heroin users started with prescription opioids, most of the time coming from friends and family. So, what about the can kick? Can we get rid of this? This is actually a graphic that comes from a paper that Tim Miller and his fellow published recently. The old way of doing things, you notice at the bottom, the base, the foundation to the pyramid was opioids, okay? And then as you build upon that, you would go to other things. The new way is to say, let's use all the other things first and reduce our bit of the opioids. There's also some evidence that you can have a mean change in the amount of opioids prescribed by department simply by doing education and beginning to think about individualizing how much does a patient need when they go home based on the type of case and based on what they've consumed from the time they're in the PACU until the time they're heading out of the hospital. How many of you are familiar with Thomas Kuhn's work on paradigm shifts? You've heard that term earlier. Saul was using that term. And what happens is you've got this pre-science and things are forming, and then there's normal science, and this is where we went through the 80s and 90s and all this, proving maybe which opioid was best. Remifentanil, you have a faster wake-up. The problem is you have a lot more hyperalgesia as well. Then you get into this model drift, and people start saying, hey, how can we do it a bit different? And then you get into a crisis. And I think where we are right now is that in order to kick this habit, we're really at the point of a crisis, not so much the opioid crisis, but how are we going to treat perioperative pain, and how are we going to help with the opioid crisis? That's the point where we are in our care. And then what we're going to have is a model revolution. So if you think of paradigm shift thinking, instead of how long can the central line or Foley stay in, it shifts to why isn't that out yet, right? How many of you in training, if you gave 1 unit of red cells, you might as well give 2, right? I mean, if you're going to bother the blood bank, you might as well bother the blood bank, right? If you're going to put a central line in, until there's pus coming out of the wound, keep that thing in there, because we also thought that CVP had something to do with volume status. Right? So paradigm shift thinking is where you really just have to turn things on their head and begin to ask the question a different way. So I'll leave you with 3 questions. Why would an anesthetized patient need any opioids? If a patient has taken no opioids for 24 hours prior to discharge, assuming they had major surgery, why would I send them home with any? And if a patient has taken minimal opioids for 24 hours prior to discharge, why would I send them home with a lot? So, can we kick the habit? Yes. And I'll leave you with the question of, ethically, should we? Thank you very much.
Top Med Talk.
Don't forget, of course, you can meet the Top Med Talk team simply by attending one of our meetings. Now, if you go to the EBPOM website, ebpom.org/meetings, I'll give you a good idea of where we are. But I really must mention to you now the email updates that we do. Make sure you're signed up for them, and then you'll know exactly what we're doing and when we're doing it, including when we're streaming this kind of content on the Top Med Talk website. Because, of course, whilst we were there in Chicago, you could hear this on the website simply by logging on to topmedtalk.com. So get yourself there now and sign up for those email updates. That's topmedtalk.com.